So next presenting is Nesan Bandali. Nesan is a clinical trials nurse at the Odette Cancer Center. So Nesan began her career in oncology at the Hospital for Children, and after having worked many years in hematology in the oncology ward, it's Friday afternoon, can you tell? In 2003, she decided to continue her pursuit within Sick Kids, the program she loved in retinoblastoma program, as a multi-center clinical nurse research coordinator. And that began her love of clinical trials. In 2009, she transitioned her oncology clinical trials expertise from pediatrics to adult oncology by joining the genitourinary, or GU for short, medical oncology team at Sunnybrook Odette Cancer Center, working with the renal, prostate, and bladder clinical trials. And so Nesan's interests include integrating clinical research to excellent patient outcomes. Welcome, Nesan.
Hi, everyone. I'm going to be talking today. Thank you so much, Heather and Kidney Cancer Canada, for inviting me today to speak to you about immunotherapy and their side effects. Okay, so today we'll be speaking about advances in therapeutic options in metastatic renal cell cancer, immunotherapy and the mechanisms of action, and common side effects or adverse events of immunotherapy and patient management. The treatment for metastatic renal cell cancer has come a long way. We started with interleukin interferon in the 90s and the 2000s. In 2005, 2006, we had sunitinib, the targeted agents, which targeted the VEGF inhibitor, and then the temsirolimus, everolimus, pazopanib, axitinib, and now we're at immunotherapy. So it's been exciting times for treating patients with renal cell cancer. I'm not going to go too much into the targeted therapies because these are drugs that we've talked about previously, but I will talk about just the two sort of targeted agents that we've been using, in the past since 2005, which is the Sutent, sorafenib. We're now into axitinib, and those are drugs that are highly active for patients with metastatic cancer. mTOR is another pathway. These are medications that target the blood vessel, so the anti-blood vessel medications, and so this is another pathway that's come up with renal cell cancer for these targeted agents in the mTOR, which is the Afinitor and Toracel type of drugs. Clinical trials presently underway that have promising results for renal cell cancer. I'm not sure if everyone here has heard, if you've done research, there's this new drug that's being used in clinical trials it's called cabozantinib. This is a recent drug development efforts in renal cell cancer, and usually we focus on the single targets, which is the VEGF and the mTOR inhibitors. With cabozantinib, they're looking at another sort of pathway, MET inhibitors, and putting that together, and hoping that hitting those two targets will have better activity for patients. It's a drug that's already been approved for one type of solid tumor, and we're now trialing it in kidney cancer, and it's starting to make a little bit of noise as being a drug that will be active. Today we're talking about immunotherapy. Immunotherapy are also called the biologic therapy, is a type of cancer treatment designed to boost the body's natural defenses to fight the cancer. It uses materials either made by the body or in the laboratory to improve, target, and restore immune system. And it works by helping the immune system work better at destroying cancer cells. Tumors have evolved multiple mechanisms to avoid recognition of the immune system. As you can see, they turn off the T cells, so they take up this pathway that then stops the T cell from working and recognizing that that's a cell that needs to be dealt with. What immunotherapy is doing is opening up that pathway so that they're able to now recognize the tumor cell as being foreign. The pathways that they're talking about, there's many pathways that are being looked at right now, but we're going to be talking about the drugs that have been coming out for renal cell cancer, which is the PDL1 and the CTLA4 pathway. The PDL1 drugs are like the nivolumabs and the pembrolizumab. The CTLA4 is the ipilimumab. I'm just going to call it IPI. Checkpoint inhibitors, the immune system depends on multiple checkpoints or immunologic breaks to avoid overactivation of the immune system. Tumor cells often take advantage of these checkpoints to escape detection from the immune system. The CTLA and the PD-1 are one of the few checkpoints that have been studied as targets in cancer treatment. CTLA4 has been shown to be present on the surface of the T cells in certain cancers, dampening the T cell activation in response to the tumor cells. PD-1 is another immunologic checkpoint that has also been found in certain tumors, and from what I heard 2 days ago, nivolumab is one of the PDL1 drugs that has been now approved in FDA approval. Yeah, so it's exciting times. I'm going to talk about side effects of immunotherapy. There's quite a few slides, and I know you're interested in that. What I'm going to talk about is adverse events. Adverse events are effects that immunotherapy drugs, they take advantage of an adverse event reaction is an injury caused by a medication. Adverse reactions can occur following a single dose or prolonged administration of a drug. The meaning of this differs from side effects. Side effects can be good or bad. Adverse events are usually, we look at those in clinical trials, and usually those are the adverse events are things that we look at to then let the patients know what types of side effects that they can then expect to experience. And what we do is we grade it. We grade from 1, which is mild, moderate, is 2, 3 is severe, and 4 is life-threatening. You don't really ever want to go to 3 and 4. We want to deal with the side effects at 1 and 2. Sometimes you may have your doctor or your nurse ask you, when you're looking at your side effects, can you tell me between 1 and 10 how severe it is? And in our heads, we just look, if someone's telling us it's a 10, or a 7, then we know it's getting to the 7, the 3 or 4, and we need to deal with it very seriously. Immune-related adverse events. Adverse events are often low-grade and can be treated supportively. Immunotherapy drugs can cause the immune system to attack normal cells and tissues in areas in your body that may be affected. These side effects can sometimes become serious or life-threatening and can happen anytime during treatment, even when treatment has stopped. So immune therapy, once your immune system is being revved up, these side effects can, usually when you're getting treatment, you're on the treatment, you get the side effects, and the side effects are gone when you stop treatment. Immune therapy side effects can actually be prolonged because they're an immune system. Your immune system has been revved up, and so these side effects can actually go on for a long period of time. Sometimes they may not show up right away, but they may show up on the 3rd or 4th or 5th cycle. So I often tell our patients that they need to be vigilant to let us know. You can't sit back and say, oh, I've not had side effects and that's okay, because they can happen later on. And these side effects can actually be a little bit more potent with combining the drugs. Like we've got a trial with nivolumab and ipi right now, and some of the side effects that you're seeing with the combination of drugs can be a little bit more potent than just having, taking one of the drugs. This slide is about just the PDL1, so the Nivo type of side effects. So you're looking at, occasional, between 5 to 20% of patients will get fatigue, flu-like symptoms. Diarrhea is one. Rashes is another that we have to deal with. And most of these side effects can, again, be mitigated if it's grade 1 or 2. When you're getting into grade 3 and 4, that means we didn't know anything about it and we weren't able to deal with it at that point. CTL4s, which is the IPI type of drugs, have their own side effects as well. Again, rash seems to be the type of side effect that goes sort of through both of the medications or both of the immunotherapy types. Rash, diarrhea, colitis. Occasionally, you'll get pituitary gland inflammation or pancreatitis, or just liver enzymes that go up. And these are just some side effects that sort of would be looking at both of the drugs. So ocular is one, endocrine, liver, so inflammation in the liver, gut, skin and gut are ones that we really, concentrate on. Neurologic, ocular, they're usually more rare. Hematological are rare as well, and any inflammation, really, with immunotherapy, it's any inflammation that happens at any part of your body. There are allergic reactions that happen with immunotherapy as well, but that's usually when you're getting the treatment, and your nurse is usually there giving you the treatment. They know how to deal with it, and they'll give you the treatment that needs to happen. So dermatological toxicity is the most common in immune-related adverse events. It's associated with these checkpoint inhibitors. This is what it looks like. And oral mucositis is another that we deal with as well. So rash in the trunks or extremities, dry skin, pruritus, itchy skin, skin hypopigmentation. Those are things that you can look at. Managing of these could be topical creams or topical steroid creams. Others could be for itchy skin. You may get Benadryl or these anti-pruritus medications. For mucositis, we'd look to see whether you had thrush, and if you did, we would treat that. If not, then we would treat with just the mucositis type of medications, lidocaine for pain, and those kinds of things. So, and oral steroids as well, because that usually does help decrease inflammation. With any of these, if the side effects are severe, then we need to really closely monitor the patient. This is an algorithm that most of us use, and you can see on the right side, you're looking at mild and moderate and severe. So if you're looking at a rash, one of the things we use with targeted medications when we talk about rashes is that, go into the treatment, using creams and, keeping your skin hydrated and well. So that's something that you can, that we can teach patients right off the bat. And then what we do is we grade the rash. If it's a very low grade rash, again, topical creams and whatnot. As it gets worse, grade 2 or grade 3, then you're getting into steroid medication, either oral or IV. And then if it's very severe, then you're looking at immunosuppressive drugs that we have to use to counteract that side effect. Diarrhea is another common clinical complaint in patients undergoing treatment with these treatments. Diarrhea colitis is mostly present around about 6 weeks of treatment, and again, this can happen, at the first treatment, or it can happen a little bit later. But that's when studies have shown that that it does happen. Your doctor will first try to rule out any infection of the diarrhea. So you might have a stool sample that they'll send off to make sure that there's no bacteria, viruses. They'll ask you about the frequency of your stools. If you're having, diarrhea once a day, then, we would watch that. If it's come up to 4 times a day or less, that's a grade 1, so you can, take Imodium. If you've already been counseled with this and you're going home and you're saying, okay, I've had 1 or 2 stools and they're very watery, I'll take Imodium, call your nurse and let them know that, I've experienced diarrhea and this is what's happening. I've taken Imodium. They'll counsel you as to if it gets worse, then, this is what we need to do. You don't want to, again, get into a very, very, very severe state of diarrhea either. Colitis is an inflammation of the colon. You can tell that there's a healthy colon, moderate colitis, and then the severe. You never want to get to the severe colitis, because if you're getting there, you're at a higher risk for bigger problems. And at that point, your treatment will probably stop, because if you're that severe, then they don't want to put you back on the treatment at that point. So it's very important to let your healthcare team know that you've been going through this. Management would be informing your oncology team from mild to moderate. Treatment such as Imodium is recommended. If it started again, like I told you, call your healthcare providers and let them know what's happening. If it's severe, then they would probably start you on prednisone or IV steroids. This is another algorithm that we use. The middle column is the grading that we do, less than 4 and then 4 to 7, and so you really want to stay at the lower end of your side effect when it comes to diarrhea. Deal with it, and then we can go on. If it gets severe, then you're looking at being hospitalized and having to figure out how we're going to then have to, deal with the severe side effect, and that usually ends up being IV steroids. A gastroenterologist may be involved at that time. To do a colonoscopy and endoscopy to see what's happening in the gut, and then treat you accordingly. Hepatitis. Hepatitis usually, again, happens around 8 to 12 weeks. We do blood work usually prior to each cycle of your treatment, so we would be following your LFTs, which is your AST, ALT, so your liver functions are always being looked at. If the doctor finds that they're starting to climb up, depending on how high they are, they may hold that drug for that day and then watch you with serial blood work to make sure that it's coming down. If it's slightly elevated, they may just continue on with the treatment that day. But again, if it gets to the point where your LFTs are high or you're exhibiting symptoms like lethargy, itchy skin, jaundice, abdominal pain, that's getting into the serious stages of high liver tests. And so therefore, they would have to deal with that before putting you back on the treatment. So management would be your blood work, just looking to see how you are clinically, and then deciding whether they need to hold the drug at that point or treat you for the high liver function tests. This is another algorithm as to what we do when there is high liver tests, and so depending on what side effects you're exhibiting at the time, if it's severe side effects with the elevated liver tests, then that's something that we would deal with in conjunction. So we look at you clinically, and we would look at the blood work and see whether you're ready to go on to the next cycle, how severe it is, whether we need to bring you into the hospital. The biggest thing with the liver as well is that if you've got your doctor, before even starting treatments, will probably sit down with you and say, have you ever had any liver problems? They'll already know what your liver looks like with the tests that they've already taken. And sometimes if you have lesions in the liver, that might also be something that's increasing as you're on the treatment. So they need to take all of that into account when they're deciding how they're going to further treat you. Endocrine disorders, so you're looking at pituitary gland, so inflammation of the pituitary gland, hypothyroidism. There's targeted medications have that already as their side effect. If any of you are on Sutent, you would know we usually put you on a thyroid medication if it's hypo or hyperthyroid. So that's something that we look for. Again, it's in the blood test that you're going to have done anyway. So if you're complaining of a lot more fatigue, your doctor will do these tests and find out whether your thyroid is working well. You could have headache, fatigue, behavioral changes. When you're looking at behavior changes, mental health, mental status change, or vision changes, you're looking at this is affecting you a lot more than they do a lot other tests to make sure that you're okay. Sometimes if you've got vision changes, they may do and behavioral changes, they may do a CT scan to rule out whether there's progression of disease or whether there's something wrong with the pituitary gland. There's a blood test that they can do with that as well. I'll go to the next slide. So, and then usually if they do feel it's immune related or immunotherapy related, they'll put you on steroids, hoping that will decrease the inflammation in those areas, and you can go on with treatment. Grade 3 and 4, you're looking at that, so that's very, very serious, and you're looking at a whole bunch of tests that will go with that. So again, we're looking at not wanting you to be at that level of side effect that it's going to affect you to the point where we're going to have to bring you into the hospital and hospitalize you to do some of these tests. So you might have an endocrinologist that's then linked to your care, so that they're able to do some of the tests that need to get done and treat you accordingly. So this is the algorithm for endocrine management. of the other side effects that we see rarely is pneumonitis. Now, pneumonitis we also see with mTOR, so Afinitor. If anybody's been on Afinitor, you've probably or have heard about this or have experienced it. This is first of all, we would need to rule out an infection, because sometimes, when you're short of breath, all of a sudden you have a new cough. That could just be the fact that you have an infection, so we would have to rule that out. If it's related to the drug, pneumonitis, meaning that it's an inflammation of the lung tissue, then a CT scan would be ordered at that point, and your doctor will treat you. And they can treat you with either antibiotics if it is an infection, or with steroids to decrease that inflammation. Less common type of side effects are eye uveitis, or inflammation of the eye, photophobia, dryness of the eyes, or blurred vision. Kidney, which would be the inflammation of the kidney structure. The side effects could be fever, increased or decreased urine output, fluid retention. So that's something that we would need to deal with. Pancreas, which is pancreatitis. Sometimes the amylase and lipase levels will go up. If you're not symptomatic from that, and it's not a true pancreatitis where you've got the pain and loss of weight and nausea and vomiting, then we'll just watch it. I had a patient that was on a PD-L1 drug who had, slightly elevated amylase and lipase, and we just watched it, and really he never had symptoms from it. So that's one that sometimes happens, but it's not terrible for the patient. Neurologic is another side effect. So any type of changes in behavioral. Sometimes you can have a lot of malaise, fatigue, those kinds of things. So we would need to deal with that. And hematologic, you can get low blood counts, so low hemoglobin, white blood cells, and low platelets. That, again, we do your blood work usually prior to every cycle, and so therefore, we would know what's happening. If it's very low, then if it's a hemoglobin issue, you can get a blood transfusion. If it's very low platelets, then we would hold the drug to see whether that's something that's related to the drug. Assume sometimes that it is immune related. Give you steroids. Sometimes that will deal with that type of side effect. Okay. The overall management for patients on these immunotherapies is evaluating. So you're knowing what. Your healthcare team has got this information. We've been trained in these types of drugs, so let us know exactly what it is that you're going through. If you're exhibiting signs that are not normal for what you're like every day, then let us know, so that at least we're aware of those side effects. Your nurse will ask you whether you have a fever, diarrhea, changes that since starting treatment, and then they will watch you. If it's something that's very low grade, then they'll probably call you in a couple of days. If it's starting to exhibit some signs that that's uncomfortable for you, then we can bring you in and deal with it. Depending on the symptoms, if they've done the workup and they feel that you don't have an infection or the fever is not related to that, most doctors or oncologists who deal with these drugs will assume that it's immune related, and they'll treat you accordingly with steroids and go on from there. Multidisciplinary management of patients with immunotherapy. Your oncologist, your primary physician, your nurses and specialists that are involved once you do have these side effects are a very important part of your team. What you can do is understand your treatment, be aware of these side effects, understand that these side effects can happen, and let your healthcare team know. It's important to be proactive in dealing with these side effects and getting your team together. Working closely with the healthcare team will enable you to have better outcomes in these medications. Summary: be aware of these side effects. Be aware that these types of immunotherapy drugs are not all difficult to take and not for every patient. So these side effects can be, pretty well managed. But you also need to be aware that there are some areas where, they can affect good body parts, good organ function. So, we need to be able to know about this. And as we're learning more about this, the multidisciplinary team is also, like in our hospital, we've been dealing with immunotherapies in the melanoma group for a long period of time. There's some of the specialists that are working with us, the ophthalmologist or the endocrinologist, they're aware of these side effects. And so that's something that, if you're at a center, right now these drugs are in clinical trials, and so you're going to be watched very well. Well, once they come out, we'll have a lot of information on the side effects, and so your oncologist should be able to deal with that with you. Current studies that are underway right now, we've got the two sort of CTLA-4 drugs and the PD-L1 drugs combination. We're now starting to look in some studies, I also do bladder studies, we're starting to look at that as adjuvant treatments as well. So patients who are at high risk of recurrence, using it up front. And so those are some of the clinical trials that are happening. And there's other trials that are looking at actually putting in the immunotherapy. So there's the immune therapy pathways, and we're getting those and inhibiting those and looking at the targeted. So the anti-blood vessel medications like Sutent, putting those together. Some studies in other solid tumors are also looking at chemotherapy and these immunotherapy drugs. So there's a lot of research that's going on out there with immunotherapies, and hopefully that'll be beneficial to our patients. Thank you.
Thank you very much.
You're welcome.
So I think maybe we'll just do a couple questions for Nesan, just if you have any questions about the immunotherapies or the side effect management. And again, we'll just quickly start in the room to give people on the webinar a chance to type in their questions. So any questions for Nesan? Yes.
Well, how does Credit Valley carcinogenic affect expectancy level of care?
Credit Valley is an oncology center, right? So you should be able to. It depends, because these are in clinical trials, certain centers are open to these clinical trials and some are not. There's clinicalorg.org, which is clinicaltrials.org. Sorry, that's the one. So website actually has some of the trials that are going on in Ontario. So that's important to look at. Ask your doctor if they also know of any other trials that are going on in other centers that you may be eligible for. We get a lot of referrals from other hospitals that haven't opened these trials, and they know. And the doctor that I work with, Dr. Bjornson, sends out emails to his colleagues when our trials open so that they're aware of things that are going on in our center. And I'm sure Princess Margaret and other centers that have opened up these trials do the same thing. So
we have a couple questions through the webinars. So one question is, what percentage of patients experience these side effects?
When you're looking at rashes and diarrhea, those are things that about 20% of the patients do experience. There's the rare type of side effects. I've had a patient on APE and Nuvo, and they had a lot of side effects with diarrhea and things like that. So the combination therapies seem to be the one. Sometimes you can just get flu-like symptoms. I find that they're all in all, when you're looking at especially the PD-L1 drugs that we've been using in trials, they're fairly well tolerated. It's the one-off patients that so the rare patient that actually gets this heightened immune response where their organs are also involved, not just the cancer cells. So
we have a second question. Does the BRAT diet help to control diarrhea?
Yes. Sometimes yes, and sometimes no. So that is a good thing to try. The BART is bananas, rice, applesauce and toast. I got it. So that's a good thing to try. Sometimes they say with Sutin, sometimes we use probiotics, but at times that's not going to help. So, with low grade, we do, suggest Imodium and get started on that early. If it's infectious, then your doctor will do some tests to make sure that it's not an infection. So, letting us know and work with you with regards to these side effects is very important.
Thank you so much.
You're welcome. Thank you.